Did you have a class before me? Is there any class before me?
No, the class ended at 2 p.m.
Okay, so, oh, we could have done at 2 then.
But we didn't get to eat.
Okay, so you're well-fed state.
Yes.
I'm glad. I just was thinking if it could benefit you all. That's okay. Actually, I finished DOs 1 to 2, so it would not be possible for me to. So we have a minute. Okay, guys, it's 3 p.m. Okay. So what is the plan, right? So only thing is that I want to make it parallel to DO.
Some hours.
So I had only 50 minutes for DO because they were going into another class. I will do the same for you. I will do a 50-minute session of acid base balance and imbalance. Tell me another time when I can exam review globular protein. Okay. Is it clear to everyone? And please see where is your exam help. I will share these recap slides. Today, I will only share acid-base balance. When we finish globular protein, I will share globular protein also. You also have an exam one PowerPoint on the share and CP1 review PowerPoint and CP1 topic list. You have your interactive session question, your online self-assessment. Also, one announcement, please. I'm trying to sync your IS grades. I only sync one session. Also, review that. If you have any concerns, please reach out to me. Okay. I'm trying to sync all your grades by this week. Okay, so let's see what we have. First of all, CP1 lectures are tough. Please, I know there are only 14 questions. They would be second and third order. Please do not leave them to the next weekend. Okay, that's why I'm coming back and doing recaps. How many lectures you have? You have 2 lectures, you have 3 primers, and you have 2 CV. Only one CV will be tested. Content will be equally tested between 2 lectures. There are 14 questions. Okay, let's see what we did in acid-base balance. I'm going to go slow so that you can ask me question now. But the thing is, today I'm only holding session for an hour, please. For question and answer, go back, review. Monday, we will have a chance to ask question. Is everybody good with that? Sounds good? Everybody? You can hear
Yep.
me? Great. Please stick to your learning objectives. What did we do in acid base? First, we did a primer. What did we do in primer? Henderson-Hasselbalch equation and application. I will come to that soon. Then we did acid base lecture. Please again stick to your learning objective. They are tied to your exam questions for sure. We did talk about weak acid, weak base. We talked about Ka and pKa. You know very well, high Ka, strong acid, low pKa, also strong acid. We did Henderson-Hasselbalch equation. It's always dissociated or undissociated. What did we do? 3 application: weak acid, weak base, drug absorption, buffer, and charge on amino acids. Charge on amino acids I'm not doing now because it's more important for boards. Right now, we are only concentrating on our exams. But when you come for exam question session, I have a thought of keeping amino acid for that if somebody is interested with his charge. Right now, Henderson has a back equation. We did acid-base drug absorption and buffer, if you remember. Charge on amino acid, if anyone is interested, not bringing it here. We identify weak acid drug is absorbed. Weak acid, weak base drug is absorbed in neutral form. So weak acid should be dissociated or undissociated to be neutral. Weak acid should be dissociated or undissociated to be neutral. Weak acid drugs, anyone? Undissociated. For this fraction to be high, pH should be lower than the pKa of the weak acidic drugs. Where is pH low? Stomach or duodenum? Where is pH low? Stomach or stomach? So weak acidic drugs are absorbed well in the stomach. Weak base drug, to be neutral, it has to be dissociated. For this fraction, neutral fraction, dissociated fraction to be high, pH should also be high or low. For this fraction to be high, high. Where is high pH? Stomach or duodenum? Duodenum. So weak base drugs are best absorbed in the duodenum. We did Henderson-Hasselbalch equation. I'm not rushing over this content. Know the reference range, 7.4 pH, 100 PO2, 100 chloride, 40 PCO2. Tell me what's bicarbonate, reference range. Anyone? Bicarbonate reference range. Bicarbonate reference range. Don't memorize the ranges, please. They don't know the reference range, 24. And anion gap is between 8 and 16. Good to know it. We know according to the Henderson-Hasselbalch equation, when pK of a buffer is near our body pH, it is a better buffer. But no, instead of phosphate, why bicarbonate is a better buffer? Because of its concentration. We did that. Then, because bicarbonate is the best physiological buffer due to concentration, we got to understand this equation, and the enzyme is carbonic anhydrase here. Who is doing it? Why do we need to know this equation? It can go either right or left, normally in your body. Now let's see abnormal. Normally also it goes both places, but let's see abnormal and also finish acidosis here. So is low pH acidosis, high H plus ion acidosis, or both? Is low pH acidosis, high H plus ions acidosis, or both are acidosis? Low pH, high H plus ion. Both are acidosis. You got to be mindful what is acidosis. Low pH, high H plus ions is acidosis or will contribute to acid. Is CO2 acidic or bicarbonate? Is CO2 acidic or bicarbonate? Which one is acidic? What contributes to acid? CO2. Bicarbonate is a base. Very good. When you are in metabolic acidosis, now comes the problem. Your equation will shift right or left. When you are in metabolic acidosis, this equation will shift right or left. When you are metabolic acidosis, the equation will shift. Equilibrium will shift right or left. Who's saying right? Right is not right. Right is not right here. Left. And that is why in metabolic acidosis, what is the compensation? Remember, metabolic acidosis compensation is hyperventilation, where CO2 is flushed out. Right? Did we do that? Yes. So this not respiratory alkalosis, please. Yes. If you don't intervene in case of metabolic acidosis, then hyperventilation may lead to respiratory alkalosis. Does that make sense? Not otherwise. Would be inclined to think acidosis is high pH? No. So we are concentrating. Take different scenarios at different time. Don't look at all the picture at the same time. Do metabolic acidosis separate. Metabolic alkalosis separate. Respiratory acidosis separate. Respiratory alkalosis separate. So we are not mixing CO2 here. I'm talking about only one thing, metabolic acidosis. So is it clear now? Let's not bring CO2 here. In metabolic acidosis, understand metabolic acidosis. What is metabolic acidosis? Either pH low or H plus ions accumulate. And in metabolic acidosis, is bicarbonate low? Is bicarbonate low in metabolic acidosis? Is bicarbonate low in metabolic acidosis? How do, yes, because bicarbonate is mopping up the H plus ions. That's why it keeps going low. Yes, let me answer the question too. Just a second. So you understand what I'm saying? We are right now concentrating only in metabolic acidosis. Let's not bring respiratory acidosis here. Okay, just a second. So divide, no, don't do any division, please. Just take one scenario at a time. I will explain you respiratory acidosis also. Just concentrate on metabolic acidosis. Metabolic acidosis means the equation will go left and CO2 will be expired through lung, causing hyperventilation. Is that clear first? I will come to respiratory acidosis. Let's not bring all here, but okay, if you want to ask me, yes, if CO2 is accumulating in your body, then the reaction will go. If CO2 is accumulating in your body, then the reaction will go left or right. The reaction will go right. And that's why, does CO2 accumulation cause acidosis? Does CO2 accumulation cause acidosis? Right. But since this picture is not concentrating on that, I'm still yes, that is why in CO2 accumulation, there is more acid. The reason why CO2 accumulation causes acidosis is the same, but let's concentrate on first big picture. Metabolic acidosis. Metabolic acidosis. In metabolic acidosis, reaction will shift right or left. Metabolic acidosis, reaction will shift right or left. This reaction, left. And what is the compensation? That's why metabolic acidosis, hyperventilation. When it's not treated, hyperventilation can then go into respiratory alkalosis. Otherwise, compensation is hypo. Does that make sense? I know, don't worry. I will do it step by and you will not be confused. Now, metabolic acidosis, we have done what is metabolic acidosis when it's accumulating hyperventilation, but now causes, very important. Metabolic acidosis is due to gain of acid or loss of what? Can you complete it? Metabolic acidosis is due to gain of acid. It won't haunt you when I finish the lecture. Let me finish the lecture. So metabolic acidosis is due to gain of acid or loss of base, both. Tell me the example of metabolic acidosis due to gain of acids. Examples. Where does it happen? Mud piles, which is in your CV, no diarrhea. Do not go wrong. Metabolic acidosis is seen in diarrhea, but metabolic acidosis in diarrhea is not because of gain of acid. Yes, diarrhea is loss of base or loss of bicarbonate. Please indicate the base also. Base is bicarbonate. So metabolic acidosis is either gain of acid. Let's concentrate on that first. Gain of acid cause? Yes, mud piles. Open the mud piles, but give me still more common cause. Somebody diabetic ketoacidosis, excellent. Lactic acidosis, alcoholics, excellent. Then open mud pile. There's a lot of poisoning. There is salicylate poisoning. Let's focus on more common. Open the mud piles. That is also metabolic acidosis causes due to gain of acids. We will do an ion gap later. Now, tell me the example of metabolic acidosis due to loss of bicarb. Due to loss of bicarb. Diarrhea. Do not put diarrhea in metabolic alkalosis. Diarrhea is metabolic acidosis, but due to loss of bicarb. So we finished metabolic acidosis here. Now let's take which is other people's question. This is very good diagram. I have my line diagrams. I just bring them for you to understand better. Please know that when the professors in the video talk, you're lost. It's important to bring a sketch especially for these lectures. That's why I bring my line diagram. Now look at this is tissue, this is lung. The excess acid is expired as Did we do that compensation? The excess acid accumulation in your tissue is expired how? As expired by hyperventilation as carbon dioxide. Also, look at this hemoglobin. Hemoglobin is also a buffer. So what is this form of hemoglobin? You should know what is taut, relax, oxy, deoxy. What is this form of hemoglobin? Anyone? What is this form of oxy? Oxy is also known as relax or taut. Relax. But look at this. When oxygen is given up, it's not empty. What is hemoglobin taking up? What is this? What is hemoglobin occupied now with? Hydrogen. It's not empty. So what is this form where oxygen has been given up? Is it taut or relaxed, the top one? It is taut. Taut is also known as oxy or deoxy. Taut. Deoxy. You got to know taut, relax, oxy, deoxy. I will do that in the next exam review. Today, we will only concentrate on acid-base balance. So see, hemoglobin is a buffer. You got the taut and relax form also. You also understood that when acids accumulate in your body, in tissue, they are expired as CO2 by hyperventilation, right? Just schematic diagrams if they have nothing more, right? So this is oxy, yes. But when hemoglobin gives up oxygen, what does it mop up? H plus ions. So hemoglobin is also a buffer in your body. This is oxy form. Oxy means relaxed. Deoxy means taut. Now let's do respiratory acidosis. In respiratory acidosis, you see CO2 or bicarb? Yeah, only 2H. For every 4 oxygen given to peripheral tissue, only 2H plus ions are taken. Yes. Again, yes, for respiratory, you see problem, you see CO2. So now let's look at this. This is the respiratory acidosis. Where will the equation shift? Naturally, right. So is CO2 acidic in nature? Absolutely. But when CO2 is rising, give me example of CO2 accumulating in your body. When can CO2 accumulate? No hypoventilation, hypo and hyper are compensation. First, give me the disease. I'm not asking compensation. Very good. Asthma, let's forget asthma for now. Asthma is mixed acid base. COPD, excellent. Emphysema, COPD, excellent. Because you got to have the obstruction. I will explain asthma. Please remind me. Asthma, aspirin poisoning, and Tisha. You know Tisha? Where is Tisha? Where is Tisha? Tisha is in CV? Has anyone? CV, very good. They are mixed acid-base disorder. Later, first, metabolic acidosis, metabolic alkalosis, respiratory alkalosis, and anion gap. 5 topics you have to master first, then go into mixed acid-base. Please, both the lectures are tough. Don't leave them to the next weekend, please. Okay, there are only 14 questions, but good grades, don't lose them. Yes, very good. I like that. I'll come to her throwing up and taking drugs later on. Tisha is coming last, okay, because CV is last. First, we concentrate on lectures. Then you do CV. Primers last. Do primers too, because there are important concepts of primers addressed in the interactive session, but last. Primer should be last. So let's concentrate on our Tisha will come. Okay, I don't forget Tisha, right? In acidosis, Tisha will come. Okay. Yeah, she sounds fun. A lot of things are happening with Tisha. Let's concentrate here. In respiratory acidosis, yes, CO2 accumulates. pH is low because CO2 is acidic in nature. But in respiratory acidosis, COPD causes respiratory acidosis, obstruction leading to CO2 retention. But who compensates when respiratory is a problem? Who compensates when respiratory is a problem? Kidney. What will kidney try to do? In this case, in respiratory acidosis, it will try to retain bicarb. Look at this equation. This is what kidney tries to do to normalize this ratio, retain bicarb. So when you want to do these equations, do them one disorder at a time. Here we did respiratory acidosis. You can also calculate concentration of carbon dioxide by this equation. Now, you have already identified in case of respiratory acidosis, please know this is lumen, this is cell, this is blood. Dr. Shah will add more. I'm only doing basics here. Remember, sodium bicarb are reabsorbed, potassium and H plus secreted. But in respiratory acidosis, what does kidney do? Retain or excrete bicarb? In respiratory acidosis, what does kidney do? Retain or retain bicarb? That means more will go here, right? Secondly, let's do metabolic alkalosis here too. Metabolic alkalosis is either due to loss of acid or gain of what? Metabolic alkalosis is because of loss of acid and gain of what? Base or bicarbonate. Give me an example of metabolic alkalosis due to loss of acid. Vomiting, not diarrhea. Vomiting is by stomach acid content. Vomiting is a case of metabolic alkalosis due to loss of acid. In vomiting, who will compensate? Renal or respiratory system? In vomiting, who will compensate? Renal or respiratory system? Respiratory system. How will respiratory system compensate? By hyperventilation or hypoventilation in vomiting? Hypo, not hyper. So what is vomiting? Metabolic alkalosis. And what will respiratory system compensate? By hypoventilation, not hyperventilation. Hyperventilation is for metabolic. Hyperventilation compensatory responses for metabolic acidosis. That's why don't put too much information. Know only one thing. Metabolic acidosis, hyperventilation. So metabolic alkalosis would be, if acidosis is hyperventilation, alkalosis will be hypo. So please do not memorize them. Too much information on the test. You can't think right? First, see the pH. Low acidosis, high alkalosis. Don't worry about your questions. I'm going to open questions on Monday, also Thursday. We can address question right now. Let's collect the important information. Is this helping everyone? Is this helping? Great. Nobody will say no. I'm just joking. Anyways, let's go further. pH low, acidosis, pH high, alkalosis. Then see where is the significant change from normal. Bicarbonate, metabolic, PCO2, respiratory. So tell me, what will happen to acidosis in, what will happen to bicarbonate in acidosis? High or low? Bicarbonate in acidosis, low. Very good. So that is metabolic acidosis. Causes gain of acid, DKA, and lactic acidosis. What is the cause of metabolic acidosis due to loss of bicarb? Metabolic acidosis due to loss of bicarb. Anything comes to your mind? Diarrhea. So we finished metabolic acidosis. Either gain of acid, diabetic ketoacidosis, lactic acidosis, or loss of bicarb, diarrhea. Let compensation, respiratory compensate. Metabolic acidosis is hyper or hypoventilation. Metabolic acidosis compensation is hyper or hypoventilation. Hyperventilation, right? Now, if not treated, then that can go in respiratory. If that if metabolic acidosis compensation is hyperventilation and you're not treating the cause, how do you spell it in Spanish? I don't know, I'm sorry. What's going on here? What's the, okay, everybody's good? Okay, so what were we doing? Let's concentrate. Let's be in our Zen. So what we were saying, metabolic acidosis Gain of acid, loss of bicarb, gain of acid, diabetic ketoacidosis, lactic acidosis. Loss of bicarb, you told me diarrhea. Compensation, hyperventilation. When this metabolic acidosis is not intervened, then hyperventilation can go into what? Respiratory. Hyperventilation can then go into respiratory not acidosis, alkalosis. Please be mindful. Please be mindful. Respiratory alkalosis. Now let's do respiratory acidosis. Again, cause of respiratory acidosis. Anything that comes to your mind? Respiratory acidosis. Give me quickly. COPD, emphysema. Who responds? Renal. So in respiratory acidosis, kidney will respond by retaining or excreting bicarb. Retaining bicarb. Let's go to alkalosis. Again, alkalosis, bicarbonate change, metabolic, respiratory change, PCO2. Now tell me a cause of metabolic acidosis by metabolic alkalosis by loss of acid contents. Give me example of vomiting. Please don't put diarrhea in metabolic alkalosis. Diarrhea is metabolic acidosis. Vomiting is metabolic alkalosis. Metabolic alkalosis is also the same, either loss of acid or gain of what? Metabolic alkalosis can be loss of acid or gain of base. Exactly. Let's go to respiratory alkalosis. You know the response, right? If you know metabolic acidosis, hyperventilation, you just reverse that. You don't have to memorize everything. Your brain power is not to assimilate every information, right? Be smart. With hard work, do smart work. Respiratory alkalosis. Give me example of respiratory alkalosis. You're in a panic attack, right? Is that respiratory alkalosis? Common example? Yes, respiratory alkalosis. Now, panic attack. What will kidney try to do in respiratory alkalosis? Retain bicarb or excrete it? What will kidney try to do in respiratory excrete bicarb? So you know now. You know the primary cause, primary examples. They are very important. You know the compensation. Fill it with all that. Now, what is anion gap? Anion gap is the gap between measured cations and measured anions, or it is a gap between unmeasured anions and unmeasured cations. Where will unmeasured anions accumulate in your body? When do they accumulate? Anions are acid or base? Acid. Tell me where acid accumulates in your body. Metabolic acids accumulate in your body. Example. I will come to that. I'm not at keto acids, lactic acid in alcoholics. They accumulate and then anion gap is high. If anion gap is high, it has to be metabolic acidosis, but due to gain of acid or loss of bicarb. When anion gap is high, it has to be a case of metabolic acidosis, but that is because of gain of acid or loss of bicarb. Gain of acid. Please don't make that mistake. Now, since metabolic acidosis is also because of loss of bicarb, what is the example? Give me. Give me example of metabolic acidosis due to loss of bicarb. Diarrhea. But in GI, with loss of bicarb, what is retained? To compensate? Chloride. That is why anion gap does not change much. Yes, that's why in diarrhea, it is known as hyperchloremic, non-anion gap metabolic acidosis. So what is diarrhea? Hyperchloremic, non-anion gap metabolic acidosis. Are you clear with anion gap? Anion gap helps to differentiate whether metabolic acidosis is because of gain of acid or loss of bicarb. Tell me in which one of the causes anion gap will be high. Metabolic acidosis due to gain of acid or loss of bicarb. Gain of acid. Very good. Please understand that. Compensation is always normal, not treated. It can go in other respiratory disorder. Initially, know it as hyper, hypo, retain, or excrete bicarb. Please, very tough questions. If you don't follow anything, don't worry. Just listen to me, note down the points, go back. You have a weekend, you still have a lot of time. Come back Monday, we can do question answer session. Monday, I want to do the globular protein review. Thursday, we can do open question answer session. Okay. Is that good, everyone? Is this helping? I don't want to rush. I will not rush because they're very tough contents. Okay, let's go further. Please do not do any calculation. The last column is not for you. Yes, example, diagnosis, compensation. Absolutely, you should know, but you're not asked to calculate. Is there another example of non-anion? No, no, no. Again, anion gap is not done for alkalosis, please. Anion gap is not done for metabolic alkalosis, respiratory acidosis, or respiratory alkalosis. Anion gap is only and only done for metabolic acidosis. But to differentiate, yes, but to differentiate whether metabolic acidosis is because of gain of acid or loss of bicarb. That's why you do anion gap. Anion gap is done to distinguish causes of metabolic acidosis and differentiate whether metabolic acidosis is because of gain of acid or loss of bicarb. There is no anion gap for any other clinical condition. And please concentrate on more commonly where it is used. Don't bring in your scenarios here. Otherwise, acid-based questions will be very difficult. Is it clear, everyone? Where do you do anion gap? Which disorder you are doing anion gap? Give me the disorder where you metabolic acidosis. And anion gap in metabolic acidosis due to gain of acid will be high or normal? Anion gap high. Where will be anion gap normal in metabolic acidosis? Due to loss of bicarb, which is seen in where? Or hyperchloremic normal anion gap acidosis, which is seen where? Condition, diarrhea. So diarrhea is metabolic acidosis, not alkalosis. Okay, don't mess that up, please. Okay, common example you must know. Let's go further. Don't add an ion gap anywhere else. Look at this. This is Dr. Panini's questions are cases are excellent. All you got to do is how you approach them. Sometimes in sometimes in the video, it's lost. The PowerPoint, your concepts are lost. First of all, this is a case of emphysema, right? So what are you thinking? Where are you going? Where is your probable diagnosis? Tell me. Emphysema, respiratory acidosis, chronic obstructive pulmonary disease, but don't jump to the conclusion. Now confirm it with arterial blood gas analysis. Is there a low pH? Is the pH low? Is the pH low here? So it is acidosis, confirmed. Now, where is the significant change? PCO2 or bicarbonate? Which PCO2? From 40, it became 58. When PCO2 is high, is it acidosis? Are you expecting CO to be high? No, no, little is compensation. Whenever there is a large significant change, that is primary. Compensation is mild. That is why you can know right from the ABG. Yes, compensation is always small. Right from arterial blood gas analysis, you can know that what is the primary disorder. Right? So yes, the PCO2 has a significant change from normal value. So is it a case of respiratory acidosis? Yes. Now in respiratory acidosis, what compensates? Kidney or renal? Oh, sorry, it's the same thing. I need a break. Renal system. So in respiratory acidosis, kidney will retain bicarb or excrete bicarb? Retain or excrete? Retain bicarb. Look at this. Did bicarb change? Did bicarb increase? Slightly. So compensation is slightly primary. So you've got to differentiate between primary cause from history. Start from history, go to ABG. Don't forget the history. First, history, emphysema. This is chronic obstructive pulmonary disease. I think it is respiratory acidosis. Then see where is the significant change. Start thinking, don't be biased. Start thinking, I would see it in PCO2, but confirm. Then is kidney trying to retain bicarb? Absolutely. That's why it rose from 24 to 26. But compensation is mild, primary change is significant, major. Now, we will not ask you whether it's partial compensation or full compensation. But are you clear with this diagnosis now? That it's a case of respiratory acidosis and kidney is compensating. How is kidney compensating respiratory acidosis? By excreting or retaining bicarb? Retaining bicarb. Yes, if you don't intervene, the retaining bicarb can end into, if you don't intervene and you don't treat this patient, the compensation of retaining bicarb can now end into metabolic alkalosis. Then you think of metabolic alkalosis. Great, absolutely fine. Let's look at this. Now, this is case of mixed acid-base balance. Mixed acid-base balance is with asthma. Somebody asked asthma. I will clarify asthma, but look at acidosis. Look at aspirin poisoning. Is aspirin salicylate part of mud piles? Is aspirin salicylate part of mud piles? Yes. So is aspirin toxicity a case of metabolic acidosis? Mud piles is methanol. It's in the CV. I will show you. Uremia, renal disorder, diabetic ketoacidosis, paraaldehyde, which is not seen now, isoniazid, which is anti-tubercle drug, iron therapy, salicylates, ethylene glycol. You see it in antifreeze, and salicylates. Mud piles is in the end. I'll show you. It is on your CV on the canvas. So is salicylate part of that mud piles group? Yes, it's a mnemonic cause of anion gap, high anion gap metabolic acidosis. Yes, mud piles are the causes of high anion gap metabolic acidosis. So is salicylate aspirin, also known as salicylic acid, salicylate, is it part of metabolic acidosis? Is it one of the cause of metabolic acidosis? Aspirin poisoning? Yes. Now, but is this clinical picture metabolic or is it respiratory? Is the primary pathology but just by looking at the question stem? I also like how Dr. Panini has given this without showing the ABG. You got to start thinking from there. Is this metabolic or respiratory? Now, don't disappoint me there. Don't be biased. You got to look at the question stem. It's respiratory, clearly respiratory. You can't get lost with nausea and pain. What is the symptoms going there? No, she took a large dose of aspirin and her respirations are full and rapid. You got to be very mindful of the signs and symptoms, because once you get wrong with the primary pathology, you will get wrong with the diagnosis. So respiration is full. So what is happening? It's a case of, give me a probable diagnosis. It is a case of respiratory. Okay, so it's just by pain, nausea, don't go to vomiting, right? They have not told you that this pain and nausea went into vomiting and start thinking, oh, this is a case of metabolic alkalosis. No, they didn't say anything. They just said there's nausea. Nausea could be due to anything. It's not causing the clinical symptoms. What is causing clinical symptoms, which is primary here, is she took something and she's breathing heavily. So that is why, yes, that is why it will be respiratory alkalosis. You should go towards respiratory alkalosis. Yes, tell me.
So like so that's why I actually could have explained it, because we're not necessarily ignoring, but we're bypassing the aspirin part in the epigastric pain.
We are
That's
not ignoring. Very good. Why? Because they are not saying that it's leading to vomiting. there should be something severe to go into acidosis. Thus, nausea, when we are in nausea, do we go into metabolic alkalosis? For example, nausea means this person might vomit, right? But when we are in nausea, there has to be something severe to happen primarily to cause acidosis or alkalosis. In this case, you can relate nausea to vomiting, but they have not said that. So
No,
why
I thought it was because of the aspirin is why she's nauseous.
But yes, but in your Tisha case too, she ingested
Tisha.
something, but they said she vomited thrice. So
Yeah.
understand that this scenario is not taking you there. They are saying she ingested something, she has nausea, but they have not mentioned that she's vomiting so much that she can end into what?
Okay.
What can she end into if she was vomiting too much?
Wouldn't that be metabolic acidosis then? Because she's losing her acid if she's vomiting.
When you lose acid, you go into metabolic acidosis or alkalosis?
Alkalosis.
Alkalosis, please. Great question. And you got to the answer, but the correct answer is, so yes, with nausea, you may think, oh, she's going to vomiting. When I'm telling you, the best way you can get good grades on this exam is don't put your own scenario, read it just like that. So yes, there's nausea, but don't relate it to vomiting, right? Nausea may lead to vomiting if they have mentioned, oh, that nausea made her vomit 5 and 6 times like in Tisha. Then you can think, okay, she's going into, if she's vomiting too much, that means she's going into metabolic
Alkalosis.
alkalosis. They have not mentioned that. What did they directly go into? There's this high dose and she's doing a high
Panic attack.
respiration,
Okay.
tachypneic. So that's why she's primarily a respiratory problem, respiratory alkalosis. But I'll explain you why. Two things can happen in aspirin toxicity. Number one, aspirin causes metabolic acidosis. Why? Because it's an uncoupler. And what happens in uncoupler? Lactate accumulates. So aspirin toxicity causes metabolic acidosis. But look at this. This case is clearly showing large doses, but at very high doses, you don't need to remember when. We are not learning pharm here. Pharmacology will do that job, right? But at very high doses, aspirin stimulates the respiratory center in the medulla. That will lead to, if you stimulate the respiratory center, what will that lead to? Just like panic attack?
Respiratory alkalosis then.
Yeah, so that is why aspirin toxicity is usually mixed acid-base disorder, which is not in this case. They have clearly explained this is respiratory alkalosis, but aspirin toxicity can lead to, who will tell me? Aspirin toxicity can lead to which two disorders now? Which two acid-base disorder aspirin toxicity can lead to? Give me. Respiratory alkalosis and metabolic acidosis. Yes, number one. Let's go to asthma. So aspirin toxicity can lead to metabolic acidosis and respiratory alkalosis. Let's go to asthma because I think you have an asthma question too. Now in asthma, they are also tachypneic. So what can asthma patient go into? They are tachypneic. What can asthma patient go into primarily? They are tachypneic, respiratory alkalosis. But after a certain time, their respiratory muscle fatigues. There's a fatigue. So then there is CO2 retention. So asthma patient can then go into respiratory acidosis. So asthma is an example of a respiratory alkal. Tell me what asthma is an example of. Which mixed acid-base disorder is asthma? Which mixed acid-base disorder is asthma? They are tachypneic, but then they start retaining carbon dioxide. So they are an example of asthma patients. Anyone? Respiratory alkalosis and respiratory acidosis. Yes, respiratory alkalosis may go into respiratory acidosis. So mixed acid-base disorder is aspirin toxicity, metabolic acidosis, respiratory alkalosis. Asthma patient, respiratory alkalosis, respiratory acidosis. Who will tell me what is Tisha? Tisha. Tisha was mixed. What? What was Tisha case of mixed? Anyone? Anyone remembers Tisha? Metabolic, no, not metabolic and respiratory. She's not metabolic and respiratory mix. Tisha. Tisha is a mixed case of metabolic acidosis as well as metabolic alkalosis. I will do that too. So here, high dose of aspirin, respiratory alkalosis. So are you thinking pH should be high? Yes. Should pH be high in case of respiratory alkalosis? Now, where is the significant change? PCO2 or bicarbonate? Who has changed a lot? PCO2 or bicarbonate here? PCO2. Is PCO2 high or low here? Is PCO2 high or low here? Low. So is low PCO2 alkalosis? So is this a case of respiratory alkalosis? In respiratory alkalosis, what does kidney do? Flush out. What does kidney do in respiratory alkalosis? Flush out. Bicarbonate. Are bicarbonates low? Are bicarbonates low? Please know, yes, primary pathology is significant, compensation is mild, and that is why by slightly, absolutely slightly. That is why look at the diagnosis. Diagnosis is respiratory alkalosis without full compensation, but we are not going to ask you partial or full because you need to do calculation. That's not for first year. Let's go further. You know an iron gap? An iron gap is used to calculate, is used to differentiate. What Tisha? Tisha, I'm going to Tisha. You like Tisha, just like me. Tisha is coming. Tisha is coming in the end. Tisha is not forgotten. Believe me, I got Tisha in the slides too. So give me a second. Okay, so let's finish this quickly, 5 more minutes, and then we will do globular protein next time. So you know anion gap, anion gap is to differentiate different causes of metabolic acidosis. Anion gap is high in metabolic acidosis due to gain of acid or loss of bicarb. Anion gap is high in metabolic acidosis due to gain of acid or loss of bicarb. Gain of acid. Where do you see gain of acid? Diabetic ketoacidosis. And where do you see gain of acid? Diabetic ketoacidosis and lactic acidosis. Lactic acidosis, alcohol. But where anion gap is normal, in metabolic acidosis, if anion gap is normal, which metabolic acidosis it is? Because of loss of bicarb. And it's also hyperchloremic. Where do you see it in? Where do you see metabolic acidosis due to loss of bicarb and normal anion gap? Diarrhea and hyperchloremic too. Very good. Now look at this. Diarrhea. Where are you going? See, the history is very, very important. You will know that when you will diarrhea. Where are you? Where is your mind going? Diarrhea is a case of metabolic acidosis. Exactly. So is pH low? Yes. Which change is significant? PCO2 or bicarbonate? Who has changed significantly? PCO2 or bicarbonate? Bicarbonate is high or very low? High or low? Low. So where is bicarbonate low? Acidosis or alkalosis? Where is bicarbonate low? Acidosis. So is this a case of metabolic acidosis? What is the compensation of acidosis? What is the compensation? Hyperventilation. So is PCO2 low here? Is PCO2 low here? So has compensation happened? Yes, a significant amount. 40 went down to 31. So look at the diagnosis. It is a case of metabolic acidosis with respiratory compensation. Though we are not going to ask you partial or complete. No, that's for later years. No. Okay, you got it. Now let's look at this. This is what? Emergency, ketones, hyperglycemia, forgot the insulin. What is this a case of? Diabetic ketoacidosis. Where is your mind going? Give me the probable diagnosis. Where is your mind going? It's DKA. Where is your mind going? It's which disorder? Diabetic metabolic acidosis. Will anion gap be high here? Yes, it will be high, absolutely. So you know it's a case of metabolic acidosis because it's diabetic ketoacidosis, pH is low. Where is the significant change? Who has changed significantly? Look at bicarbs. Bicarb have fallen low. Why? Because bicarb is now mopping up H plus ions. So it's falling low. So this is a case of high anion gap. Calculate the anion gap when you go home. It is a high anion gap metabolic acidosis. So, and what is the compensation in acidosis? Compensation in metabolic acidosis is hyperventilation. Hyperventilation means PCO2 should be, hyperventilation means PCO2 should fall low or high as a compensation. It should fall PCO2 should fall low. Exactly. This is all you have to do. Look at the history. Now, look at this bulimia, vomiting, excess vomiting. Where are you thinking? Where are you going? What should be your diagnosis? Vomiting, metabolic alkalosis. You are not calculating anion gap here. Anion gap is for metabolic acidosis. So now look at this. Is pH high? Yes. Is pH high? And where is the significant change? Significant change is in the, because you know it's vomiting, you're going into metabolic alkalosis. In metabolic alkalosis, who compensates? Sorry, respiratory compensate by in alkalosis? By what? Metabolic alkalosis, respiratory hypoventilation. Right? Am I going correct? Yes. So is PCO2 rising? In hyperventilation is PCO2. Will PCO2 rise? You can see the PCO2 rise, right? So see what is your diagnosis. Your diagnosis is this was vomiting. Your diagnosis is metabolic alkalosis with respiratory compensation. So you should also know that metabolic, who responds? Respiratory. Respiratory problem, who will respond? Respiratory cannot respond. Renal will respond. Now let's get back to Tisha. Tisha is very popular here, more popular than me in biochemistry and genetics. So let's do Tisha here, right? If you pour acid on it, burns and leaves a. Oh, okay, okay. You have a lot of mnemonics. I'll keep doing it. Give me good grades. Give me good grades. Tisha. Tisha is a teenager. She ingested something. Any poison, any poison in mud pipes. Maybe she had a salicylate poisoning. Maybe she had ethylene glycol, which is an antifreeze. Maybe she had methanol poisoning, alcohol poisoning, whatever. Tisha ingested something which was acidic. That's why these poisons are acidic. So what should be Tisha primary a case of? What should Tisha go into? She ingested something which is acidic. Maybe salicylate, metabolic acidosis, right? But after that, she vomited. She vomited a lot. So then what did Tisha end into? She walked metabolic alkalosis. So Tisha is a case of metabolic acidosis due to ingestion of poison, but that poison made her do a lot of vomiting. So she ended into metabolic alkalosis too. So now, how do you know that it's a mixed acid-base disorder? Look at the pH. When you don't see the desired change in ABG values, then you know that it's a case of mixed acid-base disorder. Because if it was metabolic acidosis, pH should have been, if it was metabolic acidosis, pH should have been low or high. Metabolic acidosis low. If it was metabolic alkalosis, pH should have been high. But look at this, pH is near normal because she's a mixed acid-base disorder. They are compensating. The primary problem is compensating each other. But tell me, anion gap in this Tisha should be high or low? Anion gap. Anion gap should be high or normal? High. So this is a case of high anion gap metabolic acidosis along with metabolic alkalosis. So Tisha first ingested something, then she started vomiting. So she is metabolic acidosis as well as metabolic alkalosis. What do you mean by how so? Do you have any question, Amir? Let me finish this. You can ask me question quickly. Anion gap is high because remember, anion gap differentiate different causes of metabolic acidosis. In case of metabolic acidosis due to gain of acid, for example, in Tisha case, anion gap is high. That is why anion gap should be high. Yes, because she vomited because of the poison, then she lost acid content of the stomach. So she is going into metabolic alkalosis. No, 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 no. This chloride compensation does not come in vomiting, please. Vomiting is metabolic alkalosis. Chloride compensation comes in diarrhea. Diarrhea. Only diarrhea, when you lose bicarbonate by GI tries to retain chloride. That's intestine. In intestine, there is chloride compensation, not in vomiting. Okay. So she vomited, she ended into metabolic alkalosis. Her anion gap is high because normal is 8 to 16. You got to get used to calculate anion gap, which is a gap between sodium minus chloride plus bicarbonate. So does Tisha have metabolic acidosis? She didn't lose the base when she was vomiting. No, 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 no. What do you vomit? Where do you vomit from? Your intestine or stomach? HCl. So when you vomit, you're in metabolic alkalosis. Yeah, I'll give you a question. Let me finish the 2 slides. So if students want to leave. So Tisha is a case of metabolic acidosis. Why? Because her anion gap is high. Otherwise, you can't do that from pH. You could never know that. But due to poison, she vomited. So she has also gone into metabolic alkalosis, also has it. So that's why her pH is normal. And because she's both in metabolic acidosis and alkalosis, please, vomiting is not a compensation. Please, compensation is hypo, retained by carb, or excrete by carb. So Tisha is a case of metabolic acidosis as well as alkalosis. And this is mud piles. Open mud piles. Mud piles is a cause of cause of metabolic acidosis and high anion gap. We'll review globular protein on Monday. Any question? Good luck, everyone. Yes, tell me.
So I have one quick question, and
Yes.
my brain could go too far with it, but we'll see. So for like, I know tissue is